of all, I'm going to say what is a poor prognosis patient from our perspective in the embryology lab, and talk about the importance of giving realistic hope and managing expectations for this group of patients, and then discuss some of the laboratory tools that we use for these patients. So the poor prognosis patients I'm going to discuss are those with a decreased antral follicle count and a high FSH, those that are likely to have a low number of oocytes collected, patients with previous failed fertilisation or poor embryo development, patients that have had recurrent implantation failures or recurrent miscarriages. So to start with, then, the patients that are likely to have a low number of eggs collected. So from the literature, we know that multiple studies have reported that the association between the number of eggs collected and live birth rate in IVF it proves that the number of oocytes to maximise the live birth rate is around about 15. So therefore, those that are having a single egg collected, or likely to have a single egg collected, we have to manage their expectations right from the beginning. So at CARE, we're lucky that we are a large group of clinics, and we can look at data from within our own clinic to provide patients with this information. So from this is a retrospective analysis from 7 CARE clinics in over 5 years, and we had 487 oocytes, all singly collected. We looked at the clinical outcomes, and we compared them to concurrent patients with more than 1 egg collected. And there were 38 babies produced from those 487 oocytes. And this proved highly significant differences between the concurrent groups for all of the clinical outcomes. So the conclusions were also for the embryo transfers. 54% of all patients with a single oocyte collected did achieve an embryo transfer, and then at least 1 in 5 of those patients 40 years and under achieved a live birth, and 1 in 29 patients in the over 40 group achieved a live birth. So this data is really helpful to us to set realistic expectations for these patients. Then again, looking at the patients that we're expecting 3 or fewer oocytes to be collected, we asked ourselves, does ESHRE improve the clinical outcomes for these patients? Should we be offering ESHRE purely because of the number of oocytes collected? And we again looked at the literature. There was no agreement. Some of the papers suggested that it would improve the fertilisation rates and clinical outcomes, but there were also papers that said it didn't. So again, we looked at our own data, in-house data, same time period, same number of clinics, and we had 980 cycles in that group. We compared the clinical outcomes again, and we had 926 with IVF and 54 with ESHRE. So we found that the fertilisation rate per mature eggs was significantly higher in couples with IVF, and all the other clinical outcomes were similar. So again, we can say that the choice of fertilisation technique should not be based on the oocyte number. So, for patients with previous failed fertilisation or previous poor embryo development, we've got a couple of laboratory tools that we can offer: the COMET test and artificial oocyte activation. The COMET test, so that's looking at the percentage of DNA sperm damage. There are three main sources of it, and there are also temporary and reversible sources of it. We offer the test to patients that haven't had an infection or a high temperature within the last 3 months, so that we're getting accurate results from that. So the semen samples are frozen and sent to in liquid nitrogen to a testing laboratory, and they're thawed out, and we get a report about the percentage of DNA damage, which they calculate. So if the results show a high percentage of DNA damage, we can offer the patients a course of at least 3 months increased antioxidants to decrease the reactive oxygen species, either via diet or mainly supplements. After that time, we can test again. If the COMET test is still elevated, we can suggest ESHRE as a treatment to obviously decrease the amount of sperm around the eggs, or even a surgical recovered sperm via TZ or TZA, because sperm damage occurs during the epididymis, during the sperm travel down the epididymis. And oocyte activation. So this is a natural event which causes a rise in intracellular calcium concentration. It completes meiosis and the extrusion of the second polar body, and also the cortical reaction. So we very cautiously introduced artificial oocyte activation for this set of patients over the last 5 years. It is not CE marked for use at the moment, but there aren't any other CE marked alternatives available, so we can offer it. We have a lot of patient consent and information documents to give to them, and we offer it to patients who've had previously low, less than 33%, or failed fertilisation with ESHRE in the past. So again, the literature, it tells us that there's been a meta-analysis of 14 RCTs in 2017, which have shown it to have a positive outcome for both fertilisation and the clinical outcomes. So we offered it to patients, and we found in that group of patients that have used it, the fertilisation rate, the mean fertilisation rate has increased to 49% for these patients. And then we compared it to patients who didn't use it and also had a low fertilisation rate of less than 33%, and found that all the clinical outcomes were significantly increased by offering it. Recurrent implantation failure. So implantation failure is when there's no sign of implantation following embryo transfer of good quality embryos in repeated cycles. And recurrent miscarriage is the spontaneous pregnancy losses at less than 24 weeks, and if it occurs in 3 consecutive pregnancies, we consider it to be recurrent. Our treatment options are laboratory tools that we would recommend for these patients are Embryogen and Blastgen and PGTA. So again, we looked at our own in-house data regarding the use of the Embryogen and Blastgen based on the previous clinical history. And we introduced Embryogen into care in March 2013. At that point, there wasn't a Blastgen. So the embryo transfers occurred either on day 3, or if they were a blastocyst transfer, the embryos were put into our standard culture medium after day 3 up until day 5. So we found very promising results from these patients, especially after the Blastgen was introduced in 2016. So this data was on the first 17 patients that we had using the Blastgen, and what we found, obviously the numbers are low and we couldn't do it significantly, but we found a trend towards higher clinical outcomes and a lower biochemical loss rate using the Blastgen. We have my colleague Sue has looked at the data recently, and the numbers now are a lot higher. 134 patients have used Blastgen, and the biochemical loss rate has increased slightly, but it's still 14%, so still very comparable to the other two groups. We know that it is a viable tool to offer to these patients. So PGTA, the reasons we use PGTA are to shorten the time to live birth and to reduce the chances of an aneuploidy pregnancy by aiming to avoid the transfer of a aneuploid embryo. So we looked at the euploid rate and age of our care data, over 2,000 embryos, and we found the euploid rate about 31%, which is in line with the literature. So in 2017, we had a look at compared our clinical pregnancy rates for embryo transfer with or without the PGTA, and found significantly higher clinical pregnancy rates with the PGTA patients. We've also looked at the vitrified stored untested embryos and warming them, 80 patients over 18 months to 2017, to have a look at the effectiveness of performing a biopsy on these embryos, to offer patients the chance to screen the embryos that have been cryopreserved without being tested. And we found that first of all, that the survival rate of these embryos was nearly 95%, and there were 32% euploids, which again is in line with the literature, and it has resulted in a clinical pregnancy rate of 52%. So again, that's a good information to give to patients to manage their expectations. These are just some of my colleagues from different care units that I'd like to thank who provided this data.